And now part 2 of our interviews from the University of Washington Medical Center in Seattle, focusing on the critical role both pathologists and medical laboratory scientists play in driving the healthcare for Americans. Seattle is the epicenter of the coronavirus outbreak in the United States. It has been astonishing to see the Herculean efforts of this lab team working tirelessly to get the needed assay up and running in order to take care of patients not just in Seattle, but around the nation. The dedication of our lab professionals and pathologists who have risen to the occasion unlike any other practitioners in healthcare is amazing.
I'm Dr. Blair Holliday, the Chief Executive Officer of the American Society for Clinical Pathology, and today I'm privileged to sit with a distinguished guest, and that is Dr. Alex Gruninger. Alex is a physician, a pathologist, a researcher, a scientist, but baked into one, a laboratory professional dedicated to the health of patients around the world.
I'm an assistant professor at the University of Washington in the Department of Laboratory Medicine and an assistant director of the Clinical Virology Lab here at the University of Washington Medical Center.
I'd like to hear your story.
So we started testing March 2nd, and we performed probably about over 13,000 tests to date. Unfortunately, we've probably detected the virus more than 750 times by now, doing about 1,800 a day, finding about 150 infections a day. And so it was really like we've been able to fill in that first piece and sort of have our laboratory developed test be a bridge and available to people in our area and across the nation to provide early testing for this virus because there were no tests.
Have you ever seen anything like this?
You know, this is a very unique virus and its ability to transmit, cause high morbidity and mortality, generate so many cases, and cause lower respiratory tract disease.
In your personal or in your professional opinion, Alex, where do you think this country is in that bell-shaped curve?
Our job in the clinical virology lab is to bend the curve and to stop the transmissions. So we try to break the models that other people create. Right? We want to detect virus, we want to stop the virus, we want to stop transmission, and we want to break their model.
My job is to flatten it, and my job is to make sure that we create or provide enough rapid assays, turnaround time, so that patients don't have to worry about what that curve looks like.
I mean, that's why you go into clinical pathology, clinical medicine, is because you can be the change.
Why is it that the laboratory is the central portal, more or less, for my determining whether or not I have this condition or this disease?
You know, you don't really clinically, you can't distinguish this virus from other viruses. You have to test for it. You have to find its genetic material, right? That's how we know that this virus is present. So it requires laboratory testing. We have a long history and a great deal of comfort with these sort of materials, protocols. People are well trained, and that's why you should have comfort in our results. So it starts with our clinical providers who collect the swab. Our specimen processing people are very good at making sure that we're going to have the right patient, the right tube, the right results. And then those specimens come here to our clinical lab where we have people who are also experienced at pre-processing, extracting, making sure we have controls on every single run, internal controls in every well. They're experienced at PCR. We've got a great research team as well to help us continue to validate and try. That's been a real key part. I mean, the supply chain for this test has been so dynamic. The regulatory environment has been so dynamic. And so to have extra people in the lab who can do the research, that allows us to validate new tests, to alter our supply chain in a 48-hour period, but make sure that those tests are still accurate. And then a clinical testing team basically makes sure those results are continuing to go out at a clip of, we're doing 24, 25 runs a day on our high throughput extractors. So everyone on this team has interacted with ASCP. They're certified at different ASCP certifications across the board. People, I think, often overlook the sort of sociological, the organizational aspects that sort of ASCP allows us to make sure there's a pool of trained people who can execute these tests, starting 48 hours after we're allowed to test. That's really, you can't train everyone, in that time period. And that is really where ASCP has been very helpful in regards to this particular response.
Can you imagine doing anything else with your life in terms of your profession?
I mean, I didn't necessarily expect this to happen by any means, but I think lab medicine has really always stood out to me as an opportunity, clinical pathology, as a way to contribute to medical care. You get that sort of every result matters, but you also get to take these sort of also bigger decisions that sort of affect your clinical colleagues and how they execute their clinical care.
What advice do you have for a potential medical student looking for a dynamic career within medicine?
So I think lab medicine is a fantastic specialty. I mean, it really allows us to take advantage of all the gains we get in informatics and computational sciences. They're very well integrated into laboratory medicine. You get the management aspects as well, and then you can have a real big impact on testing. There's always new tests. There's always new things to test for. There's always new platforms. There's new ways to test for, right? We can distribute these tests even potentially out of the lab. There's all sorts of new revolutions occurring in laboratory testing, and this is where the science meets medicine. And so this is where, especially in this area where there were no tests, and we can offer sort of one of the first tests, you can have a big impact.
We have a wonderful opportunity here to talk to Gregory Pepper, who is the laboratory manager here at the University of Washington Clinical Laboratory, serves as a lab manager. So he has a large cohort, large team that he has to orchestrate.
At this point, yes. I was the lead scientist here for many years, and then about 3 or 4 years ago, I moved more into the management side of it. I really missed the lead scientist part because that's the interesting part. That's what you really enjoy. But putting people in the right places is just as important as doing it yourself.
Tell me through your eyes, in terms of how your team has responded, what you've seen and the lessons learned that you could pass on to the rest of our colleagues across the United States.
We started off on the Monday when we first started testing, and we were asked, can you guys do 300 to 400 tests a day? And we're thinking, 300 or 400 tests a day, how are we going to fit in 300 or 400 tests a day? Because we're still doing clinical work. There's still people out there for a lot of things that still need results. So we can't just drop everything and just go to COVID testing. And then they said, well, we got to ramp this up to 1,000 samples a day. And we're thinking, well, that's going to be a little bit tougher. So next thing you know, everybody's working 24/7, 7 days a week, all shifts. And then they came to me and said, we really need to do 5,000 samples a day. We're not quite to 5,000 samples a day, but the next day they said, it would really be good if you could do 10,000 samples a day. We're recruiting from the other divisions. There's great medical laboratory scientists out there. There is a slight training curve because every discipline takes some training, so you can't just take, person from A and plug them into B and it goes. So there is that training period, and we got to maintain all the quality control. We can't just, you want a quality result. You don't want just the fastest result. The most important thing is to get the highest quality result at the quickest turnaround time. These things are high complexity testing, and the background is there. So even if you're working over in transfusion services or you're working in chemistry, you have the background of how the quality control needs to work. So when you come over to our lab, we can teach you the process. They can pick up the process relatively, even though it's completely new to them. They know what the process is. They know what the quality control steps are. So,
Greg, what do you think the biggest misconception is about the work or the role of the medical laboratory scientist within the public?
Well, on Sunday night I was watching 60 Minutes, and they were showing a couple of nurses. It was great. They had a swab and a vial of viral transport media, and they were calling that a test kit. And they were going around swabbing, and the general public thinks, okay, there's my test. It's done. There's the test kit. I'll get my result back. But that's just a collection kit. From there, there's a long process of testing. So even once the sample reaches the laboratory, it's about a 6 to 6.5 hour turnaround time before we can get the result out. And when you have that many, you get that backup. So the pre-analytical part, the analytical part, and the post-analytical part all plays a huge role in getting that quality result out in a reasonable turnaround time that's relevant or significant to the patient's outcome. And automation has played a big role for our throughput. But basically, the automation is just taking the manual stuff that's the straightforward manual stuff, and it's doing it for us. The actual thinking, the process is still done by an MLS or a medical laboratory scientist. So at the end of the day, like for our PCR reaction, you still have to analyze that data, decide where the cutoff is, decide, is this good data, can we go with this back? There's always those ones, the 80% of them are pretty straightforward, but it's that 20% that are right on that edge. Is this positive, is this negative? That's where the experience of the medical technologist comes through, because otherwise, you get a negative result when you should be positive, or vice versa, and that really has a significant role for the patient downstream, and not just with COVID-19, but with a lot of different things they're looking for.
There's such a dire need for more of these scientists to support us, particularly for reasons just like we're witnessing here in this epidemic.
As a group, and I'm in that group, we're an aging group, so we need those younger people to come up and sort of take that football and run with it.
Well, that's a credit to the program directors of the medical laboratory science programs in the United States. It's a credit to the accreditation system with NACLS. It's a credit to, obviously, the professors and individuals such as yourself choosing to be a dedicated change agent. And it's a privilege to be talking to Arun Nullah, who is a PhD researcher here at the University of Washington, Arun, tell us a little bit about yourself, your work, and really what's happened and transpired in terms of the innovation that you were part of this team and one of the leads in this team to support the development of the test and get ahead of the curve, so to speak, so patients can get access to diagnoses.
It all started with when we had the first patient in Seattle. At that point, we thought that, okay, this is the first patient, it is a travel-based, and we are not in a danger. And we started working on that when we developed a basic assay using all the information what we have, and we started to validate that assay, but we don't have a clear positive sample to completely validate it until we received the second positive, and that's when it started. Like, we have the positive sample, that's the limiting step. We don't have the positive sample to validate our test.
What preliminary steps did you take and your laboratory team take in order to sort of get ahead of the curve so that you could provide testing and ramp up quickly? I know that you support the rest of the country as well. You're getting patient samples from New York all the way to Chicago, all the way to, the East Coast and the West Coast. So tell me a little bit about that journey, and I'm sure that you had an inkling in what you did in order to get yourself prepared and your laboratory prepared.
But once we know that that the positive samples are increasing, we need to change that into a high throughput. And it went to a next extractor which can manage 96 samples at a time. And day by day, the sample volume is increasing. So we need to validate it into high throughput machines, other high throughput machines. So everything is challenging. Like, each day we think, okay, we are done with the validation, but we come up with the next thing, okay, the sample volume is increasing. We need to validate in a bigger machine.
Are you running into any problems with supply chain?
Like, for the first week, we thought that, okay, we have done it, and we are okay with whatever supplies we have, and we ordered everything so that it will be sufficient for 2 or 3 months. But all of a sudden, we receive the supply chain is back ordered. So we have to look for a new instrument there. We can't work for the instrument, it lasts maybe for a couple of days. So we have to look for the new instruments and the supply chain in that, and we need to validate that in the new instruments. And without compromising on the quality or the sensitivity of we should maintain everything the same.
How does that make you feel as a scientist, that the world is now focusing predominantly on you and your profession?
Right now, at least I can say that I have contributed something to in this COVID-19 thing. Like, we have developed an assay, and right now we are testing it. So I think I see that as a contribution.
I'm also joined today by a very special guest, Dr. Keith Jerome, who is also a physician, scientist, pathologist, researcher, MD, PhD, here with the University of Washington, and I'm going to let him tell you a little bit about his work.
I'm a professor within the Department of Laboratory Medicine at the University of Washington. I also head up the virology division, so keeping all this big, complicated program running. At the same time, I'm a member at the Fred Hutchinson Cancer Research Center and actually do research on the viruses that aren't making the news right now, or cures for HIV and herpes and HPV. But right now, everything's about coronavirus because we're trying to take care of our patients.
In your career, have you witnessed anything like this before in terms of the immediacy in order to turn around a test result for patient care and the concern that might be in the general public? Is this something that, one, you saw coming or you've ever witnessed before in your career?
There's nothing close, frankly. This is unprecedented, and I've been telling people for a while this is the largest event in our lifetimes. The immediacy is tremendous, the need is huge, and looking back now, we actually started to prepare in January. So we actually saw this potentially coming, and I'll be honest, I was quoted as saying, I don't think this is going to come to the U.S., but I want us to start getting ready. And the one big decision that we made that was right was to say, let's start getting ready. We've been doing thousands of tests. We did 2,300 tests yesterday. It's a tribute to the staff in our lab. They're working incredibly hard. And these are the preparations that need to be made. So what people want right now is a test result. They want it to be accurate. They want it to be correct. They want it to be fast. And what makes all that possible is the staff in the laboratory, our staff of medical laboratory scientists, everybody who has every role that makes all this work. The average person comes into the hospital, they think of the doctors and they think of the nurses, and they should. But what they don't see, or most people aren't aware of, are the people in the background, the people in the laboratories. Every time blood's drawn, every time they say we're going to order some tests, all those things go to the lab, and there's this huge staff of these people who work tirelessly to make this happen. I will tell you, our staff is working 80, 90 plus hours a week right now to do this. And I'm telling people, actually, you guys got to go home. I know you want to do more. I know we want to get another test out. But we also have to take care of ourselves so that we can do this again tomorrow. It's an amazing, amazing mobilization of a really impressive workforce happening just in record time.
If you were asked tomorrow to give a speech to talk to the incoming group at your medical school, what would be your conversation with that group to consider clinical pathology as a dynamic opportunity for being a doctor?
It's a fantastic career. You can turn it into almost anything you want. If you love that patient contact, there's aspects within even this field, you can have that directly. If you're interested in doing basic science research like I am, there are options to combine clinical care with that and really focus that basic research on things that'll help people. It's such a broad field. Every day is different. I've never been bored. I've been doing this a long time, and I love coming to work. You know, people ask me when I'm going to retire, and I say I have zero plans of that because it's just too much fun and there's too many needs.
The last word.
We're in for a rough patch here. There's no way around that, and things are likely to get worse before they get better. We have an amazing healthcare system. We are working now together with the folks who are working on vaccines to help facilitate their work. There is hope out the other end. Science works, medicine works, the American healthcare system works. It's not all going to happen as fast as we want, but we're going to get there.